first speech. Deputy President, I rise to speak on the health legislation amendments, and I welcome the bipartisan approach taken by the Coalition in restoring integrity and maintaining the sustainability of Medicare. As you know, Deputy President, Medicare is our most important safety net. It is our most important safety net. It doesn't matter how many zeros you have in your bank account or what your postcode is. Once you have a health scare, it tends to level the field. It levels the field. And all Australians, irrespective of their background, require a strong health system that can catch them in their moment of need. And I know that acutely. I have looked after thousands of patients in my near 30-year career, and all backgrounds, rich, poor, everything in between. And a public health system is the cornerstone of our health system. Yes, 55% of Australians are now have private health insurance, but the private health system tends to be a high-throughput system, which tends to look after slightly lower acuity patients. If you have serious health problems, you will need the public system, because that's where the complex medicine occurs. And I am also aware, and I was distressed by reports in the media of a spate of allegations regarding Medicare fraud. Medicare fraud. It actually made me quite angry, because I know overwhelmingly the workforce in this sector are there to do the right thing. These are individuals who have committed their lives to delivering high-quality care to the highest ethical standards as the Australian people would expect. Our nurses, our doctors, allied health professionals, social workers, physios, occupational therapists, our support staff who run hospitals, who ferry patients from A to B, carting them around in their gowns. These are the people who hold up the sky as far as our health system goes. And so when we have a small group who are using Medicare as a piggy bank or an ATM effectively, then it casts a shadow over the whole system and raises question marks in the minds of Australians. So this legislation was born out of a review that was led by Dr. Pradeep Philip, and it was initiated by the Health Minister, who pulled an emergency handbrake and basically brought together a team of people to scrutinise what was going on in a rapid review type fashion. And hence, a whole range of amendments have been brought into place to essentially grant the Commonwealth greater powers to investigate and to gather in evidence and then, of course, to prosecute. So I would caution any bad actors out there that we are watching you, and this legislation will now pass thanks to the bipartisan approach in this chamber. Medicare was, I would argue, the centrepiece program that we took to the Australian people at the last election. There's a reason the Prime Minister every 5 minutes was holding up his Medicare card, because Australians recognise that Medicare is one of the most important social and health and, I would argue, economic programs that we have in this country. It is the ultimate safety net. And Medicare is now 40 years old. It was introduced by the great Bob Hawke in 1984 when I first came to Australia. And I remember Bob Hawke. He was a figure writ large in my memory. He is one of the reasons why I sit on this side of the House, but of course Medicare is the other reason. And Medicare, however, was in trouble when we came to government. Bulk billing rates at the start of 22 were described to be in free fall. Free fall. It's not our language. That was the descriptor used by the president of the College of GPs, who is not known to use hyperbole or to exaggerate. In fact, the College of GPs actually, in the start of 22, issued a circular to their members to start increasing their out-of-pocket fees, because general practice was on a precipice of viability. And hence we pulled an emergency handbrake the following year in our budget, putting in around $6 billion into the system in order to triple the bulk billing incentive for the biggest users of Medicare, who are our pensioners, concession card holders, and of course children. So this patient group is around 11 million Australians. They constitute 40% of patients who use general practice, and they use around 60% of GP visits. So it made sense to target this group. And we learned a lot from that process. What we actually saw was, in a year's time, an uplift in bulk billing rates. So bulk billing rates, a year after that policy was instituted, actually lifted 2%, 2.1%. Doesn't sound like much, but it translates to 103,000 additional bulk bill visits per week. And that happened pretty quickly because those general practices did their math and they realized that if they bulk bill these patients, they're going to get an incentive and they're going to make more money, and that's going to enhance their viability. But the interesting thing was the uplift was greatest in our regional communities, which is just the best news ever, right? For too long, we have had this health-wealth divide in this country, and it's based on postcode, where the regions have always suffered on just about every metric, whether it be health or economic. The two are tied. So to see an uplift of nearly 6% in Tasmania, I worked in Burnie Hospital, I've worked in regional Tasmania, is fantastic. To see an uplift of 4% in regional Queensland, I've worked in Rockhampton and Gladstone, also great to see. To see an 8% increase in Bendigo, regional Victoria, was astonishing. And that was just with 1 year. So we'll be watching closely to see what happens to bulk bill rates. So having achieved some success, and I don't want to overstate it, these are green shoots of recovery, really, in Medicare, right? It's about arresting and then reversing that decline, that free fall in Medicare bulk billing. We've now gone further. We've decided to take this thinking, the idea of an incentive to encourage GPs to bulk bill more, slap more incentives on top of incentives, to the tune of $8.5 billion. It's a lot of money. That's a big down payment into Medicare. That is going to flush through the system on the 1st of November when that triggers. And that is in response to the $8.3 billion that was ripped out of Medicare a decade ago by the then coalition when they froze rebates, Medicare rebates, for at least 6 years. And we didn't just cook up this idea. We sought advice. And in fact, this idea came from the AMA. The AMA have been for a long time advocating for a substantive injection into Medicare. And we designed it in this way in order to actually get the outcome we want, which is to lift bulk billing rates, to give Australians what they want, which is the ability to see a bulk bill doctor again. That's what they want. We weren't going to ever just tip more money into the rebates, because I'm not convinced that supporting ever-increasing rebates will actually deliver the outcome we want. Rebates can keep rising, but so can out-of-pocket expenses. There is no ceiling on the two. They tend to correlate. They tend to travel together in parallel. So what we are trying to do is actually bring down forcibly the out-of-pocket expenses and lift rebates at the same time. And that's what this policy is designed to do. Now, our modelling suggests that in 5 years' time, in 2030, 9 out of 10 GP visits will be bulk billed. I'm aware that there was a report recently suggesting that a quarter of GP practices will not be adopting this. Well, I say to those GP practices that competition is a consumer's best friend. When you are surrounded by 3 and 4 general practices that will likely adopt this, then you risk oblivion, basically. Your patients will vote with their feet. They will vote with their feet. So we will be looking forward to rolling this out. I think Australians absolutely understood what this meant for them at the last election. And this is about ultimately front-loading this health system. Finally, as a person who spent way too much time in big hospitals, all I did was catch disasters and emergencies at the bottom of the cliff. That was my day, from morning till evening, on calls, 7 days a week. This was my life. And we need to front-load our primary health system in order to prevent patients from becoming sicker and sicker and then ending up in hospital. But there are other measures around strengthening Medicare that will also do that, and one is cheaper medicines. It doesn't get talked about enough. Cheaper medicines are incredibly important for patients with chronic disease, and 1 in 2 Australians have chronic diseases. 1 in 2. That's 50% of the population. Everything from heart disease to hypertension to diabetes to hyperlipidemia to a range of other rare diseases that affect a large proportion of our population. And these require medications that they will be taking chronically for years. Not weeks, years. And it costs money. So what did we do? When we came to government, the general script was around $42. We slashed that to $31. Biggest cut in the PBS in about 20 years. And then we've gone further at this election by cutting that to $25, which will start on the 1st of January. Now, that's good news for the 3 million Australian women who are aged between 45 and 64, like me, my vintage, who are struggling with perimenopause and menopausal symptoms. We are the sandwich generation, Australian women. We are the sandwich generation. We've been caught between raising children and then dealing with aged parents. And the last thing we need is another whammy, the triple whammy of dealing with the symptoms of menopause and perimenopause when we're trying to balance so much else in our lives and maintain our physical health, which is not easy when you enter your 50s. So what we have done with menopause has been an absolute game changer for women. By listing a whole range of medications, we have dropped the price of these from private scripts costing between $55 and $60 a month to now $31, and then from January of next year, $25. Drugs like Prometrim, Estrogel Pro, these are used by millions and millions of Australian women. But for a long time, there has been a health-wealth gap where only women like me who have the means can afford these drugs. Now we will democratise these medications for millions and millions of Australian women. Go and have a conversation with your GP, please. We're also ensuring that the endometriosis clinics, there were 22, we're going to increase that to 33, will have the expertise in-house to provide the information and look after women my age who are dealing with menopause. So not only will these clinics be able to manage endometriosis, which is an incurable chronic disease, they will also be able to provide advice on pelvic pain and menopause, effectively becoming hubs for women's health, which for too long in our health system have been the province of specialist hospitals in major cities. And that information has been siloed, it has not diffused out into the community. And this will change that. We've also instituted a new rebate for menopause, making it cheaper for women to actually go and see their GP and have a longer discussion on menopause treatments. But we also realise that GPs do not have the necessary training, and hence we will be working with the relevant colleges to develop what are called living guidelines on how to deliver best practice care. These living guidelines are effectively like a roadmap for medical practitioners. They are extremely important. They are evidence-based, and because they are living, they will evolve as the evidence changes with time, as new medications, for example, come online. I'd like to give a shout-out to Senator Marielle Smith and colleagues in this chamber for their work in the Senate on the Medicare menopause inquiry. Thank you, Deputy President.
Thank you, Senator Ananda-Rajah.